Welcome to the afternoon section of the House GovOps and Military Affairs Committee here on Thursday, February 16th. We're going to turn our attention to our OPR bill and specifically language that we heard about for the first time yesterday around expanding the scope of public health hygienists. So legislative counsel's here to zero us in on that section, and we'll hear from some of our guests. Thanks, Tim.
Thank you very much, Chair McCarthy. For the record, my name is Tim Devlin, Legislative Counsel. Before you, you have an updated draft of the bill. Draft 3.2 in particular, and that should be dated to today, this morning, 9 o'clock. The new language has been highlighted, and it is in the new section 4, which breaks across page 6 into 7. And has its own reader assistant heading labeled dental hygienist. And this would amend Title 26 VSA, Section 642. And I defer to the chair if you'd like me to go into any further detail than that at this moment, or?
No, I think there was there any change to what we were talking about yesterday? I think there might have been one small.
Yes, there were, we added in an organization for organizational purposes to provide additional clarity, additional division into the pharmacy technician language. That came up. No substantial change. It just actually properly expresses the intent. And then also there was a, I should also note that the previous section 8 regarding licensure and registration and licensure for under the pharmacy section as well, previous section 8 has been removed.
Great. So the sections have been renumbered.
Yes.
And so we're looking at, went down to that pharmacy type piece. So we're looking at the language that section 4 starts on the bottom of page 6 for the dental hygienist piece.
Yes. And that adds one new section of substance. And there is a more superficial change regarding what to call rules, not guidance, in the section above. More housekeeping.
Okay. So the substantive section is the new subsection. I think we had a little bit of a primer on this issue. Are there any questions about the words on the page or what we're looking at in terms of the bill before we let Tim out of the hot seat? Great. Well, I would like to let Tim go, and I'll invite David Englander back. Bring this up for us.
Good afternoon. My name is David Englander. I'm the Senior Policy and Legal Advisor to the Department of Health. I'm delighted to be before you again. Let's speak very briefly. First of all, I have to do a little bit of cleanup. Representative asked me yesterday about FQHCs and whether or not there were public health hygienists practicing FQHCs. And I said I wasn't sure, that I was over my skis. As it turns out, I was not wearing any skis and my eyes were closed. So let me give you a much better answer. So there are, a person can qualify to be a public health hygienist under 26 VSA 624. They can work in a healthcare setting or a non-healthcare setting. So there are, in fact, and I want to be clear, there are 16 total in the state today, public health hygienists. There is one, 16, 16. The majority of those work in non-clinical settings, long-term care facilities, and schools are two good examples. There is one public health hygienist who works in an FQHC, but her qualification is incidental to her employment. So I did want to clear that up a little bit, and that there are public health hygienists who are employed, who are not employees of the Department of Health, for instance, schools and non-healthcare settings. But that's the intention, is you have the ability to provide hygiene care in settings that aren't a hospital or art dental clinic. Those services are covered by Medicaid. So I appreciate the opportunity to clear that up. I just had the pleasure of speaking with, I want to make sure, Gallivan, is that?
Yes.
Okay, so I just had the pleasure of speaking with him, and we discussed how this is somewhat a last minute proposal. And as you know, I think maybe folks don't know, I came sprinting down from appropriations upstairs. It is somewhat last minute. This is something the Department of Health has been working on for approximately 2 years, and we've been trying to find the right vehicle and the right way to go about this. I think it's admittedly last minute. It is something that the department views as urgent. It affects a small number of providers, that it's 16 providers, but it could have massive effects in terms of their ability to treat particularly children, Vermonters, particularly children across the state, and with no discernible downside. There are not hazards associated with the use of SMART. So I wanted to acknowledge both of those pieces. And with that, I think I want to defer to the chair. Do you have any questions for me or?
Yeah, I guess just for the committee's sake and for the sake of understanding. So this is the board, the department have been discussing whether it was appropriate for SMART to be used by public health hygienists for some time.
So Lauren Lehman, who is here from OPR, would be better able to speak what's been presented to the board. The matter has been presented to the board in discussions between the department and OPR. We agreed, Lauren. We agreed that it made sense because it in essence affected the practice of dentistry, that it made sense for it not to be regulatory the way the previous treatment we talked about yesterday briefly, SDF, silver diamine fluoride application, that was accomplished through rulemaking. We agreed that it made more sense for it to be statutory.
And
that was not the model of a clarity of an answer, and I apologize.
yeah, so I just
do you want me to start again?
So here's what I'm trying to get at. This is not a new issue to folks who are aware that there has been interest in having public health hygienists do this procedure. As you said, the department's been working on this very thing for a couple of years. So while it's last minute in front of us, the new House GovOps and Military Affairs Committee, last minute idea for us to consider as a scope expansion in our bill that's been before us, it's not last minute in terms of it's not a new idea out there for professionals.
Let me try again. That's exactly right.
Okay. that's kind of what I was getting at here. Okay. So, I believe you brought, I believe you have somebody who's here to testify who is a public health hygienist or works with them or trains them.
So Dr. Echternock does training for SMART. And so he's here to present to the committee on the procedure as well as his experience in the field.
So maybe that's the best next step is to have the committee understand a little bit more about the context of what this procedure is and why the department is suggesting we include it in the bill. So David, thank you very much. If you please stick around.
Absolutely. I will try to be more brief.
No problem. Dr. Echternock. Please take a hot seat. Welcome to House GovOps.
Good afternoon, everyone. Thank you for inviting me here, and I'm happy to be here, and I appreciate you taking the time and the patience to hear me out. And I will do my best to not be a dental nerd and to get too technical. I do have 5 slides I'd like to show, and I believe someone can, if I may, stand up. To do this. So if we could.
Yeah, so we actually, it's our practice to have, and I have your slideshow before us. It's under your name on our website. It's our practice, especially when we have folks testifying via Zoom, to use our electronic devices to see slides. So if that's okay with you.
Sure. The slides are on people's computers?
Yeah, I have.
Oh, sure. That's fine. Okay.
It's on mine right now.
That's perfectly fine. No problem.
Yours is the one that starts with.
Yeah, no problem. Okay, so.
Has the X-ray.
I think before I get into the slides, I'd just like to tell you all a little bit about myself. My name is John Echternock. I am a retired dentist. I do hold an active license to practice dentistry in Vermont. I retired 6 years ago. I practiced for 40 years in New Hampshire. During that 40 years that I was in New Hampshire, I did spend 20 years in leadership in the New Hampshire Dental Society. I was an officer. I was on the board of trustees. I was also a delegate to the ADA National Convention for 4 years as a delegate. And in my retirement, I thought I could retire, but I found out that I really couldn't. And I have been working with the Office of Oral Health very closely for 6 years. I did a project with them in 2017 with the Board of Dental Examiners to get to allow dental hygienists to use silver diamine fluoride. But that's enough about me. Let's get to the slides. So that first slide, SMART, S-M-A-R-T, that is an acronym for Silver Modified Atraumatic Restorative Technique. And if you could go to your next slide. What exactly is a SMART? A SMART is a technique that will allow us to stop decay dead in its tracks so it won't go any more deeply into the tooth. We utilize two materials to do that. We use silver diamine fluoride, which I may refer to as SDF, that's the acronym, and we also use glass ionomer cements. And when you combine these two together, you can do this in a single appointment. You don't have to use any Novocaine. You don't have to drill any. In fact, I refer to these as no drill fillings, and it is important to make the point that it is not necessary to remove tooth structure to provide this filling. Next slide. The rationale for expansion of care. What we see is I think we probably have enough providers, but what we don't have is we really don't have enough geographic distribution of these providers throughout the state. And it's not just in Vermont, it's everywhere in the United States. I think if we're just creative in how we can use our providers, and I like to use the term provider because in dentistry, there are a lot of people that provide care, not just the dentist. The dental hygienist is also someone we can refer to as a provider. I think it's very important that when we use non-dentist providers like a dental hygienist, that they are supervised by a dentist. I feel very strongly about that. And I think, as the second point makes out, that we should definitely use general supervision. By utilizing general supervision and by utilizing our workforce more creatively, we can provide a lot more care for a lot more people that need the care. And I could go into detail about the necessity for more primary basic dental care in the state, anywhere in the United States. There's just a lack of it everywhere we go. But this is a way that we can provide some basic dental care for more people that really need that care. Very important that these providers are well-trained. I'm a real stickler about that. I was asked by the Board of Dental Examiners when I was there in January, when I presented this concept. They asked me to create a training program. They've had experience with me in this. I did one in 2017 for the SDF program. The training program is done. It's in the hands of the faculty at the hygiene school up in Williston. They're helping me go over that. But the training program will be very strict and it will be very formal and very thorough. Next slide. The dental materials that we're using, silver diamine fluoride and glass ionomer cements. It is really important, people, that you understand that they are classified as essential medicines. And this term essential medicine is a very specific label. The World Health Organization has created a definition for essential medicines, and an essential medicine needs to be very easily applied. It needs to be inexpensive. It needs to be effective. But most importantly, it needs to be safe. It has to be a material that even if it might be misused or used improperly, it still will do no harm to the patient. I started using glass ionomer in the 1980s. I've probably done I don't know, 15,000 fillings with glass ionomer. I started using silver diamond fluoride in 2013 when I was still in practice, and I've treated 3,000 people with SDF. I've never had an adverse response, and the literature will also show you that there really have been no adverse response with either one of these materials. That point is very important to make, because I know that one of the things that you ask yourself, will we be putting the public at risk if we allow this to happen? You will not be putting the public at risk if you allow well-trained dental hygienists to utilize these materials to do smart restorations. Next slide. The clinical protocol for doing this is very simple. You need to clean the cavity well. You apply the silver diamond fluoride. Then you apply the glass ionomer filling material. You let the filling material set up and you dismiss the patient. Again, you don't have to give any Novocaine and you don't have to drill the teeth. There's no pain involved. When the kids jump out of the chair, they give you a smile and they give you a high five. It's as they say, it's priceless. But that's pretty much the end of the slides. I think one last thing I should mention very quickly is that what I'm asking here is to just give us another tool, another building block that we can use, that all of dentistry is using to try to create a structure where we can provide more care for more people. I had a few quick words with Patrick before we started, this is really a tool that can be utilized not by just in the public health sector, but it can also be used in the private sector and in a private dental practice. And I think it's important that everyone understand that the Vermont State Dental Society, the Vermont Dental Hygiene Association, the Office of Public Health, of Oral Health here in the state, people like myself, we're all on the same team. And all we really want to do is try to provide more care for more people.
Representative Morgan, I just was wondering if you could talk about how many potential patients sort of need this kind of repair done and what the kind of challenges are. If you could go a little bit deeper into talking about the need to expand the scope so that we can provide this care to more people, if you have any of the kind of rough numbers.
Like statistically, how many people in the state of Vermont that might need this type of care? Well, I don't know if I was just at a Zoom yesterday with the Vermont Oral Health Advisory Panel, and I was not paying a lot of attention when they were going through the statistics. I'm a clinician, not a researcher. But anyway, I can tell you this much. There are roughly 170,000 children and adults in the state of Vermont that are on Medicaid. If I may just make a quick tangential point here, this isn't just about Medicaid. This is about everybody that needs this type of dental care. There are plenty of people in the state that are not on Medicaid that still struggle to get the dental care that they need. This is a simple tool that will help those people also. But there are 170,000 plus people on Medicaid that can certainly benefit from this. Does that help?
Sure.
I can tell you this much, that nationwide, 80% of all the decay can be found in 20% of the population, and we can pretty much assume that 20% of the population are the lower socioeconomic groups within our population.
Representative Morgan.
So tied into what Chair said, Dr. Upjohn, it's not limited to just kids. It's the whole,
Thank you. It is definitely not limited just to children. And this is sometimes a point that's missed. I was a general dentist, and I found that when I employing all these SDF and glass ionomers, it was such a huge help for my elderly population.
Yeah, so it's kind of, I think, two more pieces to that. That said, I mean, this is first I've heard. I'd call it revolutionary in terms of I mean, it could be employed by virtually every dentist, it sounds like, to save people a lot of drilling, a lot of Novocaine shots, and a lot of trauma in the chair, so to speak, you know what I mean? Do you see that expanding, becoming more expansive? Are there roadblocks? Are there reasons for pushback not to do it in general? And maybe I'm getting outside of the scope of this, but I'm just kind of curious because there was new news to me yesterday when we first talked about this stuff. So I think it's revolutionary, like I said, in a sense that I know you said 2013, you used it that far back, but yeah, I'm just.
I really don't think there are any roadblocks out there. I mean, I think I've been in dentistry almost 50 years. I think it's been 50 years if you want to count dental school. And it's amazing when I talk to, it seems like every week when I have conversations with people and I talk to people in the street, I find out that more dentists are starting to use SDF. And it makes my heart sing. It really does.
That's all I want to hear. Thank you.
Representative Cooper.
Thank you. So chemical properties completely safer. It's not a new, oh, gee, we found out something afterward. We shouldn't be doing this kind of stuff. It's been well tested.
I'm sorry, I'm a little hard of hearing.
Toxicity.
The toxicity, well, I can tell you the toxicity for SDF, I don't know if there's even a toxicity for glass ionomer. Essentially, if you look at the chemical formulation of glass ionomer materials, it's basically very similar to two structure. You have phosphate groups, you have fluoride groups, you have calcium groups in it. It is truly the only material that will bond with a tooth.
And the other chemical, the silver fluoride.
Silver diamine fluoride, the
fluoride that
LD50
everybody's
dosage,
complaining about.
LD50 dosage for that, which means at what point is it toxic? We use 1 drop of SDF when I can treat 5 teeth with 1 drop. And a bottle contains close to 350 drops. And I believe there was a study done, and I can't give you the details exactly in the study, but the study was done that if a 5-year-old child were to drink 2 bottles of SDF, they might hit the LD 50/50 mark.
So is there any qualification between how bad the carie is to begin with, whether it's just enamel into the any other limitation on its use?
I think I understand your question. You can use, wherever you have decay, you can use SDF.
Okay.
The one thing I've heard people say, well, if the cavity goes too deep, if it goes into the nerve.
Yeah. Toxic.
What is it? No, it's not. What you will do, you will at least stop the breakdown and destruction of the tooth structure, but you still have an infection in the nerve. That is a completely different issue from decay. Then you're talking about needing a root canal, and nobody likes to talk about root canal.
Yeah, I agree. And you're saying that this is something that can be administered effectively by a non-dentist.
Oh, it is. It is right now. It's being done by dental hygienists. It's been done by dental hygienists since 2017 under general supervision in this state. I have done. I do training programs in this. I have a CE program. I do. I've done it 53 times. I've done it in Vermont, New Hampshire, Massachusetts, and I was invited out to Minnesota to do the program for the State Dental Therapy Association. I should mention that I'm a huge proponent of dental therapists. It's very, very safe. And it can be administered by people other than dentists. And they're trained. That's a key point.
Representative Higley.
I guess I have one question I haven't heard really. How long does this stuff last? Do you put it on and then the first chance you get to do an actual cavity filling, do that? Or can if you had a young patient, could it last for 10 years, 20 years?
That's a good question. That people ask that all the time. If you put it on a tooth And if it continues to meet the physical characteristics as time goes by, and simply put, if you put silver diamond fluoride on a decayed area, and if that area remains black, as long as it remains black, that decay is arrested. And, you know, we do sealants today. We all know what sealants are, I think, a sealant. A sealant, we teach sealants. We use glass ionomer to do sealants all the time. And really, when I talk about this with people, this is kind of more like this is belts and suspenders. We're going to use two agents that are known to arrest decay. And look, nothing's permanent, and there's no guarantee that something is going to work 100%. It's very effective. Studies, there was a study done in Canada, published in the Canadian Dental Journal in 2021, January. They did a really, really good study, and they found it should be applied ideally twice. And that's just because of environmental factors that may go on if you only do it once. You got a tongue getting in your way, you got a lot of saliva. It's what's going on in the mouth. But efficacy rates were 96.2. And most of the studies will show that it's 90 plus efficacy. And those studies go back 20 years. SDF has been around since the 1960s.
So Dr. Echternack, thank you for the presentation, for being with us today. I know one of our next witnesses has a hard timeout, so I don't know if you can stay with us in the gallery here, and we'll hear from Patrick and Dr. Reyes, and then kind of open this up for a committee discussion. So Patrick, if you want to come up and. Thanks for being with us and organizing some testimony on short notice. I appreciate it.
Thanks, Chair McCarthy, and we're delighted to be here. We were caught off guard a little bit by this addition to the rules, and so we want to kind of comment on the process as much as the actual thing, because we do believe that there is value at places for what we're talking about today. It's about, for us at the moment, it's about process and making sure it's done right and well, and taking account of all constituencies. What I'd like to do before turning it over to Dr. Reyes is I did receive a letter about 12:30 from another dentist who'd like to go on record. If it's okay if I read that letter, it's a relatively short letter.
Sure.
Thanks. Dear committee members, thanks for the consideration of matters pertinent to the dental health of all Vermonters. I apologize for submitting my testimony in writing, but due to the surprisingly short notice, my simultaneous presence at another meeting supporting the dental health of the Vermont community, I respectfully request you entertain my concerns with the proposed amendment. I support the application of silver diamine fluoride to areas of visible decay as a temporary measure to slow the progression of decay until such time as a dentist can diagnose and definitively treat the decay. I do not support the blanket treatment of application of a glass ionomer sealing material over decay, no matter who's placing the material. This comes from almost 40 years of finding undiagnosed deep decay under sealants that, as they degraded, hid the progressing tooth destruction that they covered over. I can't even count how many times I would see a new patient with decay so deep that the root canal therapy was required under this preventative procedure. In my practice, I only selectively seal teeth if the positives outweighed the negatives. Having that said, I would never consider universally covering teeth treated with SDF for fear of being unable to track those surfaces visually in the months following. Additionally, glass ionomer fillings and other bonding materials are designed and tested on sound tooth structure. Tooth structure that has been degraded by decay does not have the same capabilities of a leak-proof seal, and therefore runs a heightened risk of premature breakdown and situations such as I described above. That is why it is imperative that a proper diagnosis by a dentist precede any covering over decay, and that these teeth receive definitive care. All citizens are entitled to treatment clearing the same bar. My second concern is that, like with other dental treatment procedures delivered to Vermonters that the rest of the profession provides to its patients, any training should be directly approved by the Board of Dental Examiners. My last concern is that the patients in Vermont programs will be paying for definitive fillings under this proposal. When these fillings fail and have to be replaced by a proper decay removal and restorative techniques by a dentist, Will Vermonters and state government have again to pay for this treatment? I support the application of silver-diamine fluoride as a temporary measure as allowed under the existing statute. It is a great tool when used appropriately and a great measure to slow the decay of process down until definitive treatment. Health equity is important to all of us, and I and many other dentists spend countless days in many settings, in many meetings, researching and supporting the ways we can increase the size of our provider community and access to care that meets a uniform standard for everyone on one treatment tier. I encourage you to devote your efforts in those directions, supporting provider recruitment and supporting a fiscally viable dental Medicaid program as the governor is requesting and your constituents deserve. Let's work together to help everyone get the care they need rather than spend time on Band-Aids that push the definitive care off to the future. Thank you for all your efforts on behalf of Vermont citizens. I know your focus is on doing the right thing in all your deliberations. I'm available should you have any follow-up questions. Respectfully, David B. Solomon, DDS. And David is a dentist here in Vermont. And I just want to let you know that I'm the executive director of Vermont State Dental Society. We represent 80% of the market share of dentists in Vermont. And as I said, we have concerns, not that this isn't a tool that can be used, but it's used in the right places at the right times. And I will, if it's okay with you, Chair McCarthy, I'll toss it to Dr. Steve Reyes, who's president of the State Dental Society, who will be able to far better explain the society's position than I could.
Yes, please. Yeah, thanks for being here, Dr. Reyes and Patrick. So thanks for joining House of Ops.
Absolutely. I'm pleased to greet the members of the governor's, the Government Ops and Military Affairs Committee. And I thank you for all you do. I can imagine that what you do on a day-to-day is rather taxing, to say the least. I come from a background of U.S. Public Health Service. I was in the Public Health Service for 21 years in Alaska. And I served Alaskan villages with a high dearth of dentistry, as well as an extremely challenging access to care. We worked very collaboratively there with dental hygienists, and they were an amazing part of our team. We would fly out to the villages as dentists and set up in a church, school, gym, whatever we could get a hold of, do the exams, do radiographs, do diagnosis, and then come up with a treatment. And then the dental hygienist would fly in after us and actually help us render that care. So I really have a lot of faith in that model. And I'm not calling any of that into question here today at all. Just some comments I wanted to share with you for your consideration in terms of whether or not to add this language. Some concerns that I have in regards to this, let me just preface this by talking about silver-diamine fluoride, since that came on the radar, even though that has been approved for years. That's something that I've utilized since I was in Alaska years ago. I moved to the Upper Valley of Vermont in 2015. And it absolutely has changed the face of dentistry and the way that most of us practice. I'll give you an example in pediatric teeth. Sometimes a child may be 5 years of age and have dental caries present. And what we do here in a private practice that I'm now working in outside of the public health is place the silver-diamine fluoride, which hopefully will arrest the decay. And if it does that, and we can gain enough time for the permanent tooth to replace it, then we all win. The child never has to undergo a restoration, and it's brilliant. Having said that, it's not always effective. That should be done in conjunction with preventive maintenance, as well as dietary adjustments and oral hygiene, because there are many times where I'll utilize silver-diamine fluoride and find that it doesn't actually succeed long-term if the patient is at highest caries risk. So it's great if you use it in the right applications. It doesn't always succeed by any stretch. The other concern that you'll note if you search the literature is that if you use silver-diamine fluoride in an event where the decay is very deep and near the nerve, we call that, the pulpal tissue, It is known as being a pulpal irritant if it's too close to the actual nerve of the inside of the tooth. So you do have to be a little bit diligent in the utilization of that. But all of that being said, I'm a huge fan and advocate of the use of silver diamine fluoride in dentistry. I think it's an amazing. It's as close to magic as I've seen in my 35 years in dentistry. Hygienists, in terms of qualifications and their ability to place glass ionomers over lesions that have been treated with silver diamine fluoride, to me, there's absolutely no question that they're qualified to render that type of care. My biggest concern, however, and I'll give you an example, a real life example, is when I go into the operatories this afternoon, I may see a child with a large carious lesion, essentially a hole in a baby tooth. And then I have to assess and decide what is the best treatment and care for that particular presentation. Many times, if it's a larger lesion, I like to have a radiograph or an x-ray. And why? A radiograph or an x-ray will give me an idea as to whether or not that tooth is alive or vital, or whether it's been so affected by that decay that the nerve has died and now we run the chance of having a dental abscess form. So if you're in the field, which obviously I've found myself in that situation in the past, if you don't diligently diagnose the appropriate utilization of this technique, you could place silver diamine fluoride and a glass ionomer filling into that hole, and that child may later develop an abscess because that tooth may not be symptomatic. And the reason it may not be symptomatic is because the nerve may have expired as a result of the decay reaching the nerve. So this isn't benign by any stretch. I think the other follow-up concern that I have is that this is considered, so the name has changed. It used to be called ITR, or interim therapeutic restoration. This is talking about the glass ionomer, or the filling material that would go over the silver diamine fluoride. So essentially interim, meaning that it's a temporary restoration. My concern is if a child or an individual receives this procedure and assumes that it's definitive, it's final care, and they carry on as though it's done, they're all set. Really, that lesion should be followed and or receive definitive care, meaning that be taken out. We remove the decay that's present in the tooth in place of final restoration, or as close to what we consider a final restoration ultimately. So that, I think, requires specific and significant consideration. I understand more than many what the access to care issues are in Vermont. It's something I fight every single day, especially with these poor kids that need care, and I can't get a specialist to help them because they do have Medicaid insurance. It's something that we battle on a daily basis, and coming from public health service background and having retired from that, I can tell you it's definitely a big part of my heart. And so I'm all for anything that increases access to care. My primary concern with this being proposed are multifold. One is that it came very, very suddenly. We, as a Vermont State Dental Society, didn't receive any notification that this was going to be proposed, nor did the Board of Dental Examiners. I think have been massaging it a little bit, but they hadn't come to any definitive conclusions on it. And so I guess my recommendation today to you all making this decision would be to consider the fact that there are many stakeholders and that are involved in the process. And so to me, the most logical approach to this is to let a board of dental examiners, which aren't dentists, it's composed of a very nice composition of dental hygienists, dentists, and even members at large that can go through, debate, come up with advantages, disadvantages. The board is responsible for defining the scope of what this practice would be. They have to make decisions such as, will a hygienist be required to have an endorsement on their license to be able to provide this kind of care? And then define rules and regulations as well as mandatory training and compliance. Right now, there is an expanded duties function training that already is in existence, where a hygienist would go through training to receive the EFDA approval, and that allows them to place restorations. So we have something like that in place already. But I guess I would recommend that rather than do this in what appears to be a bit of a non-customary fashion, in adding it to the language, letting it go through the Board of Dental Examiners, getting some feedback from other stakeholders such as Vermont State Dental Society membership. And then if and when they find that appropriate, and as well as have the sort of protocols in place, forward it on then to you all for approval and change in the actual language. So that's the commentary I wanted to make. And I thank you for listening to my rambling. And I apologize for my informal appearance, but that's part of the benefit of the.
You look pretty official.
I get to work in my pajamas all day. That's one of the benefits of the profession. So, here we are.
No, thank you very much for being with us and sharing that perspective. I think we need to have a little bit of conversation both with representatives from the department and OPR. We heard testimony yesterday that there would need to be rules adopted in order for this procedure to actually be done by hygienists, even if we pass this language. And of course, if we decide to include this particular piece in our bigger OPR housekeeping bill, that is really the one scope of practice bill that I would hope to work on this year. And it does have to make a stop in the Senate. So just in terms so that everybody in the public and everybody knows, this committee of civilians who know almost nothing about dentistry, I think most of us, is not really we're not making the decision about what the specifics of scope of practice are beyond just saying, is this an appropriate thing for the board to make rules on, is really my understanding. And so I just, this is one of those tricky situations for us as citizen legislators, Dr. Reyes, and for anybody who's listening at home, where the process that we have is really cumbersome in terms of, we've basically got one bill moving this year where this feels appropriate to include. And that's part of why it sort of comes up at the last minute. And we all have to spend an hour talking about dentistry on a day we never thought we were going to. So thank you so much for coming and sharing your concern. But I also appreciate you saying that, if I understood, and I just wanted to clarify before we let you go, Dr. Reyes, that under the right circumstances with the right training, that hygienists are capable of doing this procedure. That was one thing I wanted to just make.
I do, yeah, fully support that statement that you made. My only hesitation is that maybe rather than have the cart before the horse, have someone truly diligently examine and make an appropriate diagnosis for where it's appropriate to utilize that technique versus not. Indirect supervision means that these procedures could occur without previously having a dental examination. And so that's a very huge distinction. That's a very big thing that you would be passing with this language. And again, I think the language, if you put that in there, it essentially provides the ability for dental hygienists to move forward with these procedures. And then the board has to, again, as you said, place the regulations, the rules, the scope of practice and so forth forward from there.
And if I could just add one thing, in the amendment, it mentions that training should be approved by the Vermont Department of Health. That's contrary to the statute for hygienists, which says that continuing education should be approved by the board, which is the Board of Dental Examiners. So that would, I think, need a change. That's incorrect as it's latest stated in the amendment now, which just, again, is another reason why we should slow the roll a little bit, in my perspective.
Can I just get a clarification from you, Tim? It does say board in the language, doesn't it?
In subsection D, rules adopted by the board.
The email I got yesterday said Department of Health. So has that changed since yesterday?
So I think this is a great segue, actually. So Dr. Reyes, if you want to stick around, I know you had a heart at it too. We'd be happy to let you go. Patrick, if I could give the chair to Lauren Lehman to weigh in on some of those things. I think that might be the right way for us to proceed.
Thank you all so much for your time and for entertaining my comments. I really appreciate it. Have a wonderful day.
Thank you so much for being with us. Lauren, would you be willing to take the hot seat?
Afternoon, everyone. Lauren Lehman, General Counsel for the Office of Professional Regulation, for the record. So the statute, so to clarify the last question, the proposal does include training approved by the Commissioner of Health with rules for implementation and practice to be drafted and implemented and adopted by the board. So I think what I heard Patrick saying was that the typically continuing education is approved by the board. This would be prior to continuing education. It would be the actual training required to provide this service. So within the hygienist school, that would be approved in the initial proposal by the Vermont Commissioner of Health. That's consistent with other carve-outs in the dental hygienist scope for the practice of dentistry. And I'll get into the weeds there a little in a minute, but so for anesthesia, for providing anesthesia, dental hygienists can do that under the statute if they've taken training approved by the Vermont Commissioner of Health and in accordance with the rules established by the Board of Dentistry. Same with radiology. So there's previous historical examples of when hygienists stepping back, so that's why it says Vermont Commissioner of Health and the board. If there's a strong feeling that the board should be the one reviewing and approving the training, I'm not sure that OPR has a strong feeling on that. I defer to David Englander on that. The context of this is typically when the scope of practice for a dental hygienist is subject to the board's rules. They pretty much define, the dentist defines what their hygienist is permitted to perform. And that's been true for public health hygienists as well. With 3 years of practice, they enter an agreement with a collaborative dentist and they work under that agreement. There are some exceptions to this. When a hygienist has been permitted to engage in providing services that are included with the practice of dentistry under the chapter, there's been historical precedent for the legislature to make those exceptions, anesthesiology and radiology in particular. And because the SDF is more of a permanent fix, the smart treatment's more permanent fix, OPR interprets it as a treatment rather than that SDF painting on is temporary. You got to go to a dental home afterwards and get the deeper analysis and that Dr. Reyes just referred to, that follow-up care. So when that was kind of adopted and the guidelines were established for that by rule by the board back in 2017, 2018, that was under the understanding that it's a temporary fix. It's not a treatment. SDF with that glass ionomer on top of it becomes that smart treatment. It's more permanent. The person doesn't need to immediately go theoretically to a dental home afterwards. We feel that OPR feels that crosses into treatment, which is the practice of dentistry. And again, when there have been carve outs for hygienists to engage in that practice of dentistry, the legislature's been the one to weigh in on it. So that's why we feel like this bill is the appropriate route for doing this. It's more transparent. There's more folks at the table than a board meeting at OPR.
So with that said,
yeah,
if we include, so there's sort of two questions now before us. One is, if we include the language as it's written, where it says training approved by the department, but then under rules adopted by the board, do those rules need to be adopted before any hygienist can do this particular practice.
Yes, the way it's written now, it would need the board's rules, and the board's rules would dictate whether supervision could dictate how it's applied, in what settings, those sorts of situations. Actually, I take that back. The settings are established. Public health hygienists are allowed to perform services in settings that are already established in statute. But the board would have control about the manner, supervision, consultation, follow-up care. They could provide that requirements and rule.
So I want to be really clear because they can provide those requirements in rule. But hearing Dr. Ray's testimony, he implied that if we pass this language today, then hygienists would be able to do this procedure prior to the board adopting rules. And I just want to make totally clear that if it was up to me, and I obviously want to hear from the rest of the committee, but I just want to make sure we are having the professionals, the stakeholders, the board be the ones who decide exactly under what conditions and level of supervision it's appropriate to do a procedure, not us putting the cart before the horse, as Dr. Ray's described it.
Absolutely. I think, so there, right now, the way I read that language, it says that that the public health hygienist may use SMART in a manner consistent with rules adopted by the board. So that written that way, you'd think, well, how do you use it without knowing what the manner is? I think you could make it clearer. You could put an effective date on it saying, or subject it to rule saying, subject, this authority is subject to rule. I don't think we'd oppose that if you wanted to make it clearer that this should not occur until the rules are adopted.
Okay, thank you, Lauren. Representative Chase.
Would it be appropriate just to say after rules are adopted by the board and make sure that that's.
So I think since we have legislative counsel here, I mean, I think that to consider keeping this section in, I would want to make that clear to address some of those concerns. So I'm wondering how difficult it would be to, I'm wondering if legislative counsel, maybe if we took a short break, could have
Something.
an extra line or an effective date solution that would capture that this provision, this new scope would only be available after the board adopted rules.
Can I add something that might be helpful as well? I think David mentioned this yesterday, that if we had your authorization to use emergency rulemaking, we could do it on a faster basis through emergency rulemaking. That's kind of a compromise, but we would have language for that. And I'd want to talk with VSDS as well about doing that.
So committee, what I'd like to propose is that we take, say, Tim, I'm looking at you, a 15-minute break. That we take a 15-minute break, that we come back and take a look at language that includes the emergency rulemaking authority and an effective date for the whole thing that is pushed out after the board's adopted rules.
Perfect.
So I'd like to take a look at that together in 15 minutes. So we'll be back here at 2:15. So we'll adjourn